Thanks so much, Dan. It's a pleasure to be here and a real pleasure to be able to give this lecture. I first thought about it, was asked last year at the ASA. Dan came up to me and asked me about it, and I said immediately, this is what I want to give the lecture on, racial and ethnic disparities in perioperative safety. I had thought, thinking about closed claims, I assumed I was asked perhaps because I'd give one on closed claims, but I decided this, with all of what's happened with COVID, that this would be a really timely lecture. Just to go through a few points, but I do have a research grant from Edwards Corporation relating to the hypotension prediction index, which is obviously not related to the content of this lecture. And what I plan to do in this lecture is talk about the social, cultural, economic factors that create these disparities. I'm going to talk a little bit about some of the disparities that we see in anesthesia and perioperative care. And then, what part that I like the best is to be able to propose some recommendations about how we can improve this and improve patient safety and reduce disparities in perioperative care. This is a slide that we took off of collage from the internet with COVID. And I think for most of us in this audience, COVID really hit things home because you see on TV, I remember watching, in Seattle that in these lines of people getting into hospitals in New York City, most were people of color. Lots and lots of black people there. And then you hear about the disparities in death rates as well. And seeing who was coming into our hospitals. Yes, we in Seattle, Washington State was the first state that reported deaths, and a lot of them were patients in nursing homes. But overall, if you're looking at the type of problems that we see, you see that on white, in terms of, this was back in August of 18th, 2020, in that early phase of COVID, that about 33 age-adjusted COVID deaths per 100,000 Americans. But if you look on top with the red, the orange, and the yellow, and the green things, you see roughly a 3 times greater death rate of people of color than did white people. Asians are a little bit more than white people. And what do these people have? Many of these folks that we saw in New York City, they were living in tight, high-density areas. They had to ride subways and buses. They were essential workers. They couldn't stay home the way tech people can and work on their computers. And they often had a pre-existing condition. And they may be exposed to pollution as well. And they had very little access to testing. Now, I became really interested in this area, especially when I moved to the state of Washington, which was in 1986. And I worked at this hospital, you see there, that's Harborview Medical Center. I was recruited from Pennsylvania to go there and work there. It is a hospital that serves the underserved in the area. And it also is a level 1 trauma center for 5 states in the Pacific Northwest. Largely, well, some of these patients who come are ones of the worst conditions, the worst accidents and that. But many of them are people who lack insurance. And I was there back in the old days, right? We didn't have electronic health records, right? We had pieces of paper. And I was looking through a patient's chart pre-surgery, and I see this Xerox from a hospital that their system is named in the article in the New York Times about ripping off patients in this series that they had, profits over patients, but it will otherwise remain nameless. And what happened is it was a picture, a Xerox of the patient's contents of their wallet and their wallet. And here it was in my medical records. And it was from the hospital across the way. And I was like, what is this? And they said, oh, this is a wallet biopsy. This is what hospitals do when they have patients that they feel can't afford, that lack insurance and can't afford to pay, is they'll ship them on over to Harborview. So there's a little joke there. It says, Fred, we'll be able to better design your treatment plan right after your wallet biopsy. But this kind of thing existed, and it shocked me back in 1986 to find this kind of thing. My experiences at Harborview, and as well as my public health background, made me really interested in looking at things further in terms of healthcare policy. And I was fortunate enough to be selected as a Robert Wood Johnson Health Policy Fellowship in Washington, D.C. This is the reflecting pond out of the House of Representatives. I worked, as Dan said, on the House Ways and Means Committee, which in the Health Subcommittee. And for those, that is the House portion of our government that federally funds healthcare, so programs such as Medicare. Now, what I want to do is divide up my lecture into 4 different things. And I'll show you the red one first, because that's what I'll be starting off with. And these include what is the data in the United States, what are the causes of disparity. I'll show quickly some examples of the disparity that have been reported in our literature, and then some ways to help reduce perioperative disparities. So this comes from the Agency for Healthcare Research and Quality in Washington, D.C. And what they did is they were analyzing between 2015 and 2020 a variety of 24 indicators of quality of care. It's not just perioperative care, but is quality of care in health systems. And what they were doing in this slide is comparing it to white people. They have 5 classes. The U.S. standardly uses 5 classes of racial or ethnic groups. They include American Indian, Alaska Native, Asian, which also includes Pacific people as well, Black, Hispanic, and then the Native Hawaiian and Pacific Islander. And when you compare to the white population and these quality indices, you see in that I have highlighted in the yellow that half of it have the same quality of care on average as do white people. However, there is this part of really bad disparities, and that's where you have worse quality of care than white people. And if you look at it, it ranges between 28 and 43%, and it's the Black and the American Indian, Native Alaskan people that suffer worse care. There are also some interesting statistics from the Commonwealth Fund, and the Commonwealth Fund is an independent research group based out of New York City that does a lot of analyses of healthcare, of a variety of topics. This is a complicated slide, but I'll be showing you about 5 of these ones that are very similar, so I'd like to take you through it. I think if this has a mouse over here, you can see this is an average, all there, group level. And these are looking at healthcare systems overall of care on the quality indicators. This is better care, 100% is the highest ranking of all these groups of healthcare systems, and 0% is the worst. 10%, obviously the bottom 10% of all these systems. And then it's hard for you to read, but these are different states where these kind of data by these race groups are reported. Many of these in the higher end are in the East Coast, not all of them, and many of them in the worst end are in the South and some of the western areas which have large rural areas. So if we're looking at, let me go back to this from the white then say, is that you see that most of the white population is a higher quality of system care, that they're having higher quality of care in that. That it varies by state. There's some intervariability as well, which is the line that these are the averages. These are the best quality of care achieved in the state, but some obviously hospitals differ in each state, and some is sort of average quality of care. But by and large, with the white group, all you see is above that 50th percentile. Now, if you're looking at Asian American, Native Hawaiian, and Pacific Islander, they're not reported in all the states, they're only reported in part. The states probably that have larger number of these populations. But you see as well, there's variability among states, but essentially all of them are above in the 50th percentile of healthcare systems. Now, let's look at other slides when we're looking at different people of color. This is the Latinx people. what do you see? You're starting to see all these areas below here, below the 50th percentile across many states. In fact, I counted up. I thought it was maybe only a third were above the 50th percentile. These are the average values in this goldish color. These are, of course, are the best in a particular state. So there's obviously some difference here in terms of the healthcare systems that they're utilizing. When we're looking at black population, we see even worse. It's only about, I only count 4 points above the 50th percentile on average, and many of them much lower than that, even down below 10%. And then horribly, worst of all, American Indian, Alaska Native, these folks often go to Indian health system hospitals, which are, their care is terrible. They're some of the worst performing healthcare systems. So this sets up a problem then immediately with the quality of care and one of the issues that arises. Now, the AHRQ also has a way of looking at things in terms of quality of care, which I thought was interesting. And they took some of those statistics about the healthcare system performance that I provided earlier and put it here. And what you see is, here's my state of Washington. That looks like that hash mark over there is the 4th quartile, is the worst quality of care overall in the United States. And we're lumped together, the whole West Coast, Montana, Wyoming, Texas, Georgia, in some of the worst quality of care of states overall. Whereas you see the blue, that's the best quality of care overall for all racial groups. And those are largely Northeast and upper Midwest states. And the 2nd quartile, the second best, also fits with many of those. That's in the yellow. When you're looking at differences in the quality of care between patients of color versus white, we see a little different phenomena. So here, us in our Northwest area of the country, we have equally bad overall quality of care but between all racial groups. And I think, it's funny because we have centers of excellence in our state, but we have lots and lots of rural areas, lots of distance, lots of areas that are very dry as well, and you may have nothing. There are areas you drive through that's just dirt and highway. So that that is something that I think at least we're doing well. Now, so that shows us that there are disparities in care overall in the country, and I liked seeing that sort of data because of my scientific background. Now, I'm next going to move on to talk a little bit about the qualities, the causes of this, other than these hospital system-related issues. And these include issues about racism. Now, racism, in Washington, we've had a lot of training recently over racism, in particular, implicit racism. I think about racism as an iceberg, okay? Right, I've been to Antarctica, it was wonderful, but you could look, you just see a little top of the iceberg, and way down below is where the big part of the iceberg is. So explicit racism we see, but that's a very small part. We all have implicit racism. We all have preferences. We all like and feel more comfortable about people who look and talk and act like us. And that's a bigger area, and that's something that's harder to be able to come to grips with. But the really, really huge area that we have in this country is systemic and structural racism. This is our systems and our structures within the United States. Now, to start off with is just reports of racial and ethnic discrimination by different countries, health systems in different countries. And this, I think, is interesting because you can see overall in the yellow, that's the United States. You see other developed countries, they have different healthcare systems than we do in the United States, in that they're perhaps more nationalized healthcare systems. But around 30% of older patients who are minorities say that they've experienced racial and ethnic discrimination in the United States, whereas it runs around 10% or less in other countries. Who are the reports by predominantly? These are predominantly by people of color, not white people. You see, white people have very few reports of racial and ethnic discrimination. In terms of Latinx people, very high reports, and black people, 20 or 30% of these older patients are reporting that they feel overt discrimination in the healthcare situation, in our hospitals, in the clinics. And that's just, to me, shocking, but it's also really, really horrible. And something that we end up needing to be trained how to not have this happen. Now, I want to talk then a little bit about the big problem, which is structural and systemic racism. And I'll go through a few slides to show you about what they, in fact, what they are. So systemic racism is what's embedded in our systems in the country. These are political, legal systems, economic systems, our healthcare systems, our schools, and of course our jails and criminal justice system. Structural racism is a component of that, but that deals with the role of structures. These are our laws, our policies, our institutional practices, our norms and things that arise in our country. And these have been going on forever since our country has been there. And these create that huge lower part of the issue that is happening. So what sort of issues of structural racism have there been in the US? Obviously, we had the history of slavery in the US. And that, that's in our history. When slavery went away and was no longer allowed in the 1800s, and all men, not women, but men of whatever color were then given the right to vote, there was still implicit and explicit racism in an era that they call the Jim Crow era that arose until the 1960s, when there was more of an emphasis to improve racial rights. There were issues with funding of hospitals. In fact, it's a great thing. Our Congress created a thing to fund public hospitals and long-term care facilities. But these were given to the states, and the states could decide that they'll put them just in they'll have segregated areas, or they'll put less money into there. So the hospitals are worse, right? That's part of the thing we're seeing of all these bad hospital systems that people are having care in. Then there was the creation of employer insurance, right? If you're employed, you have insurance. But if you're, you work in a restaurant or you're cleaning in a place and you're a low-wage worker, you don't have that right. That was carved out of the law. And who are in those jobs? They're people of color. And then we have the issue of Medicare versus Medicaid funding. Medicare funds the elderly. It funds also very disabled people. And Medicaid funds poor people. And the funding comes for Medicare, comes from the federal government. But for Medicaid, it partners with states. So it leaves a lot of determination within states about who they want to fund, how much they want to fund, what type of health things do they actually want to fund. And so it's a different system. And then what happened is after the Affordable Care Act, there was this issue of one of the ways to get it through the Congress was to be able to carve out, to allow states to actually give Medicaid to a lower, reduce the income level that qualified for Medicaid. And then the hope was that they'd expand up for this income level of poor wage earners up to the level where they might qualify for care with the Affordable Care Act. And there were a whole bunch of states, again, largely in the South, that failed to expand Medicaid. Now, what other examples do we have? Well, we have political disempowerment. I hate to be political, but looking around things right now, we've had mail-in ballots for years in Washington State. It's very convenient. You could pop it in over a period of time. Yes, they do check them. My son was cited as having a change in his signature, and they discounted his ballot. But why not make it convenient? I remember as working in Pittsburgh having to be in line for the poll after I got out of work in the hospital as a doctor, and I almost wasn't allowed to vote. What about if you can't miss your job? You know, I couldn't miss it, but what about people working at night and can't get in during that day and can't stand for 5 blocks in a row and it's hot? There's segregation that exists around the country. There are financial practices in terms of banks and loans for businesses, personal loans. And then, of course, I mentioned environmental injustice. You don't build rich areas next to, you know, factories. They're not next to polluted water. You know, the poor people live in those areas. The poor people are the ones who live under the freeways. For rich people, where there's a freeway around them, they do a tunnel underneath. There's a criminal justice system. You know, they call it, you know, they take kids out of you know, from school. Black boys in particular are cited for, you know, and expelled from school over disturbances more than white boys are. And then the way, you know, with police and dealing with the criminal justice system, more black people are convicted and are in jails. We also have historical examples. One of the ones from my area deals with, there are a lot of Asians, is that with World War II, people were moved and their homes taken away and farms taken away and sent to concentration camps in the area. So that sort of racism has existed. And then there are issues about data aggravation, and that if you're taking 5 groups or 6 groups of racial things, there are a lot of other types of races that fit in, and we're not analyzing that kind of data. So that I'd like to then talk about the poor access to resources and opportunities. Part of it I've already talked about, but I found this article in the New York Times really interesting. This is in Richmond, Virginia, and it's on a hospital that traditionally had been, it's in a black area, it's a poor area. Most of these people don't have cars. And it was founded in the early 1900s by black doctors who were not allowed to work in the white hospital. What happened is the doctors eventually, they sold, I think probably from, you know, difficulties in funding this kind of hospital, they sold it to a big hospital system. And that was the Bon Secours Mercy Health system, with the promise that this new this hospital system that's big, rich, would build an office building nearby. However, they did not. They never did. They built it in a white area, rich area instead. And then what happened is the article, you know, they basically lost their intensive care unit, and they lost a lot of their doctors who were specialists in working there, and they lacked the resources. But in fact, the healthcare system made billions on them, because what they did is they had federal law that allowed it for funding of impoverished hospitals, you know, getting drugs for impoverished patients in impoverished areas. And what happened is they then got this extra money, but then they charged full price for to be able to get the drugs. And they moved it all out of this hospital into the other areas. So interesting thing, but this kind of thing happens. Now, the Urban Institute also is an independent research institute in Washington. We called it a think tank. It is, and they came out with this statement, I think, that was interesting. They were again looking at hospitals in terms of quality measures, and they were looking at surgery-related quality measures that we use to assess quality of surgery. The black patients had worse quality of care in 5 out of 7 surgery-related safety indicators, and in 6 out of the 11 general surgery indicators. And it didn't matter if they had Medicare insurance or not, right? Old black people in poor areas will get Medicare insurance, but it didn't matter. It still was an issue. And I think it was that part of the issue is that the black patients were less likely to be admitted to the high-quality hospitals. This is an example of some of the data that they presented in this urban report. This is numbers per 1,000 patients having a relevant surgery. There are 1,000 patients having the relevant surgery from 2017. If you look at these things in terms of post-op complications, hemorrhage, acute kidney injury, respiratory failure, pulmonary embolism, DVT, sepsis, wound dehiscence, or a perforation of a bowel, a viscus, or a vessel, they're very low in the high-quality hospitals. But look at it, much, much, much higher in the low-quality hospitals, particularly respiratory failure, almost, more than 10 times the amount of that. And so, again, that hospital setting and the quality of the hospital makes a big difference. Another thing to think about are health-harming experiences. From public health, everyone, this is one of the things you learn in Public Health 101, is that we're down here in the downstream to having medical care, and we can do things in our intervention. But in fact, to really make a huge, huge difference in the whole situation is we need to be thinking upstream in the community conditions, and the social determinants of health in that. And that's public health. And in fact, we don't fund public health very much. We fund health care. So when we're thinking about it then in these upstream things that do affect health, they're the basic social determinants of health. Now, we already talked about healthcare access and quality, right? That's an issue in a lot of poor areas. Another thing is economic stability. If you have a poor population, you're not going to have a lot of shops necessarily in the area. There may not be enough disposal of income to be able to have sort of things. And the other thing with our laws, a structural thing, is how do we fund education? We fund it through real estate taxes. So the rich houses, they get lots of money for their public schools. But if you have, your poor neighborhood, they don't earn a lot of money for their public school. So, and then we have the whole issue about the neighborhood and the environment. And the social and community context is also important in that, because there are poor areas that have wonderful social and community context, but there are others that lack that. Now, when food deserts are something that we see often as in the rural states, it's an issue where there's a long distance and you have a lot of poor people in those states. They may have cars, but they can't afford gas. And what do you get, right? You drive in rural areas, you see soda, fries, and shakes, right? That's what you see. You don't generally see fresh fruits and vegetables unless you're in a farming area that has a lot of greenery in that. Also similarly, in these areas in poor areas in cities, they don't have a Whole Foods, right? They don't have all this fresh sort of food. And so the type of food that people who live there are eating is not as healthy. This had a thing about water and environmental injustice. It had a lot of meaning to me because I trained at University of Michigan. I spent several rotations in Flint, Michigan, about an hour and a half or so from Ann Arbor. And I actually lived fairly close to there as well, because my husband went to a different school and we were commuting. But this was back in 2015. If you look at these water samples, this is taken in one house over a period of 6 days. Water, changing from, I'll go back to that, because changing from this really looks horrible, right? Would you like this coming out of your sink? To this, which is really horrible. And the type of problems that they had were lead exposure for over a year and a half. They had Legionnaire's disease in the previous year that killed people. Coming out of the city water supply, they had carcinogens in the water that were detected at this time. And what is the population? The population were poor black people in this town, and there was a task force done that had a report that they said they didn't have the same type of protection from environmental and health hazards that were provided to other communities. You wouldn't see this in Bloomfield Hills in Michigan, a really rich area, right? Immediately something would be changed. And this is, again, it's a social determinant of health that really impacts things. Now, these were some pictures I took from the internet about, playgrounds and buildings. If you look at the one building there where you see the people, the guys playing basketball, the windows are boarded up, right? The windows were broken. There's no air coming into these places. Look at the playground. It looks very, the grass is all basically gone. It's not very nice. This is where I live. Now, I must say, after the last 6 weeks of our asphyxiating with that smoke, wildflower smoke, we don't see that. In fact, it might be gone. But this park is near my house. This is one I walk to. Right, this is a rich area. This is Seattle. It's, walk along, there's greenery. Very different environmental context, right? You can be athletic and fit in our area. Very hard to do in another area. It's also hard to do when there's crime in the area. And you see the statistics coming up about gunshot violence. This is largely, if you look at that in the middle, Black and Hispanic adolescents exposed to gun violence within 500 meters of a home or school. This has largely been in those communities, not in the white communities. And then, of course, since COVID, we think about the firearm homicides. And in the Black community, if you look down here, white and Asian Pacific Islander, yes, it's gone up some, but way over here, the Black communities, 27 per 100,000 firearm homicides. And that if you think about this, it's the highest poverty level counties had firearm homicides rates 4.5 times that of the lowest poverty counties. And so again, it's an unsafe environment. There are also more drugs and other issues going in, drug abuse in these communities, which contribute to a lot of the problems. Now, all these factors then will alter biologic mechanisms, right? One of the things is that you may have is that stress causes increased aging, and that's a big issue. And stress itself isn't good either. And not only that, there are epigenetic changes that occur over generations of stress in people that alter genes in the progeny and the kids of these that. And these all lead to poorer health, which also impact things. Now, I'd like to next just talk a little bit about some of the anesthesia-related disparities because you've been getting more press about this recently, but a lot of it, were things, there have been a lot of articles coming out recently. And I'll move through these fairly quickly. Back in 2007, Larry Glantz and Carmen Green wrote an editorial about it. Carmen was also a Robert Wood Johnson Health Policy Fellow, and she's Black, and she also is now Dean of a medical school at the City University of New York. Anyway, Larry wrote this article. It's one of the first ones that I've seen about it, using a New York State perinatal database, and found that women were both Hispanic women and Black women were less likely to have received a epidural anesthetic, even when adjusted for insurance status and other comorbidities and that sort of thing. And that was one of the earlier type of disparities research in our area. There's been quite a bit more recently. These are just some examples of articles. I had a whole stack of articles I used to pick for this lecture. Black women have a higher risk of major complication after non-obstetric surgery during pregnancy. Black women had higher risk of severe maternal morbidity. They also had a higher risk of death, which is failure to rescue after having severe maternal morbidity. A lot of these morbidities were hemorrhage and rescuing from, say, hemorrhage, which we all know, you need a good hospital system and good care in order to be resuscitated from that. And the risks were highest for black women giving birth in high black serving delivery units, which are probably ones that had inadequate quality of care. Now, what about some other things? Black women were more likely to receive no analgesia for vaginal delivery. I was a little horrified. I mean, having had 2 kids, I was like, my God, you're not going to even get any analgesia, any local. You're just going to have that baby. Black women were more likely to receive general anesthesia for a cesarean section. Multiple articles over that. Again, these are adjusted for a variety of different indicators, social economic status, a need for a quick C-section, and those sort of things. White women, they're more apt to be popping in a spinal if they need to have a C-section, and they have time to be able to do that and didn't have a pre-op epidural. Black women and Hispanic women are more likely to experience undertreatment of pain after a cesarean section. They get less opioids. They had less assessments on their charts and review of their charts of having pain assessments. And if they then had an epidural or a spinal, and they had a post-dural puncture headache, they were less likely to receive an epidural blood patch, the area is epidural blood patch, and it took longer to be able to get it, an extra day. These sort of things are ones that I think are related to our anesthesia care. There's been a bunch in pediatric anesthesia as well. Natalia Jimenez had an article that said children of parents with limited English proficiency had fewer pain assessments and fewer treatment with opioids after having inpatient surgery. There's something called the adultification of black children. And that's in an article by Betzel. And that one found that black children who are less than 5 years old were less likely to receive preoperative midazolam than white children. And that black children who were 10 to 14 were less likely to have a inhalation anesthetic and more likely to have a family member present. The healthy black children were 3 times more likely to die within 30 days of surgery, and they were two times more likely to die following an unplanned reoperation. Again, failure to rescue. We have other disparities. There is an article published in 2017 that patients on Medicaid were less likely to receive antiemetic prophylaxis than commercially insured patients. This was done through the NACOR database maintained by the ASA. The VA system does a lot of their inguinal hernia repairs if it's a simple hernia under local anesthesia because they find that it does have better outcomes. And the black and Hispanic patients were less likely to have this done. They more often had a general anesthetic, despite a reduction in complications, particularly in these populations. And that black and Asian patients were less likely to receive regional anesthesia after mastectomy. Now, when we think about all these kind of things that exist, I need to think about there are patient factors. Perhaps the patients don't want to have regional blocks. Perhaps parents don't want to be present when the kid's being induced for anesthesia. Perhaps they don't trust our system and drugs and things we're giving them. There's also the healthcare system factors, which we had discussed about the poor quality healthcare systems. There are issues in our clinical encounters because we have more communication. We communicate best among people who look like ourselves. And we have few black and Hispanic doctors and nurse anesthetists. And then there are factors that we may have in some of our own type of beliefs, including bias. Now, finally, I'll end with the steps to reduce these perioperative disparities. I think this, Natalia Jimenez, who works at the University of Washington, gave me showed me this article, which I think is a really good way for us as a community to think about things. And coming back from a scientific background, I think the first thing we need to do is to study the issue. And that's the phase we're in right now. Okay, and that's one of detection. We need to figure out what are the disparities. We need to measure rates of different things, complications as well as use in vulnerable populations. We need to consider a variety of other factors. And things such as intersectionality, which we've been hearing a lot about, is that someone could be black and a woman and combined, and that all blacks are not all black, right? There are different things, and having a better way of detecting some of these disparities that exist. We also then need to understand and look in our systems about what some of the determinants of disparities are. That includes in our patients, it includes in ourselves as providers, it includes in the entire clinical encounter, and in our healthcare system. And it includes then the big thing we're going to need to be thinking about. We're in the phase where we're starting to figure out what some of the disparities are, is to be able to reduce these, to be able to intervene, evaluate, to be able to disseminate, and to actually change our whole behavior and our policy. I think one of the things that's applaud, I don't know if anyone here is from the OB committee of the ASA, but they've been really instrumental in trying to deal with this issue and come up with plans. On the top is the OB/GYN Society that has been really at the forefront of trying to deal with these problems of disparities within our healthcare systems. And what sort of things do I think that we can do to reduce them? Well, one, is the patient is part of whether they want a block or not. That can be dealt with by education. And in fact, labor epidural use by Hispanic patients has been increased by having a patient education program in Spanish. If you have better translation services, for people, and more frequently, and one good thing of COVID is now everyone has an iPad. You can often find people 24 hours, 24/7 in a language that may not be common to be able to translate nowadays, rather than having someone come into the hospital. But Natalia found that by having at least 2 sessions for these non-English speaking parents, that their children actually had better pain care and more pain medication if they were able to have at least 2 of these sessions with a translator to help be able to communicate with the clinical team. There are also things that advance recovery pathways and patient safety bundles. There's been literature both in CABG surgery and in colorectal surgery that these help erase some of these disparities in outcomes with the different patients of color. In terms of treatment of postpartum hypertension, in black patients, they found that incorporating in a patient safety bundle, incorporating telehealth in that. Now, telehealth's an issue, but most people have a phone, and you can still have telehealth via phone, even if you don't have internet service. And then there have been an article in the New England Journal of Medicine where you have all these algorithms of things. They were using an example, an algorithm to predict whether a woman could have a vaginal birth after a previous cesarean delivery. Well, that algorithm had this thing, if you were black, it gave you really high number of points that put you that said basically would come out with a score which say, no, you could not have a vaginal delivery after cesarean birth. When they got rid of that little artificial thing added into this clinical algorithm, that disparity went away. And so there's been a move in a number of areas that have been clinical areas that use these predictive things to just get rid of race out of it. There's also provider feedback. I was going to show, we're part of MPOG, and I was going to show a slide relating to it, but I didn't feel it would necessarily project. But in our healthcare system, on a preliminary analysis of our data, adjusting for type of procedure, we find that we're more, we're more often not following low tidal volume ventilation for patients who are Hispanic, as well as obese patients. So having this sort of feedback and including race in it, I think is important in that. And then finally, we need to improve the diversity of our workforce. If you look here, this is on physician, again, Agency for Healthcare Research and Policy. US population, 18% Hispanic, 7% Hispanic active physicians. 12% black in the US population, 5% physicians who are black. Most physicians are white and secondarily Asian. If you're thinking about our advanced practice nurses, this doesn't itemize out nurse anesthetists. There are fewer more black advanced practice nurses. The disparity between the population of Hispanics and the only 6% advanced practice nurses it still exists in that population. And if we're looking down the ladder at RNs, again, much more even distribution between black population and black RNs. Hispanic still much, much, much lower. And why is this important? Because patients tend to listen more and feel more comfortable and do better when their providers look like them and talk like them. That's why. Plus, these healthcare providers may move into communities that they came from and help serve those communities. So finally, I'll end with this. This is a picture of Carmen Green. I like this thing that she published in 2021 in a public health journal, because she is an anesthesiologist, but does mostly public health, and now, of course, is a medical school dean. And that includes a cycle of how we can learn to move beyond. Well, one of it is the wake-up time. I think that a lot of us are in, us both at the university, and I'm on our state medical board. We've had this too, where we're starting to say, hey, there are disparities. What are they? What are they in their system? I was horrified to find out that there was their black patient and family waiting in radiology, and they were dismissed, or they called security to get rid of them. Because they went up to the desk and they were surprised at how long it was taking to get in. That sort of feedback that comes to you really makes a lot of difference in that. We can take that feedback and we can then start getting ready and really internalizing it. And then we can externalize it and reach out to among our colleagues, which we're doing, and implement, there are things that you can learn about, well, what's the right way to say something that isn't offensive to someone you don't mean to be offensive, but isn't. Then coalescing and trying to reach out to the local communities in the populations that you serve. And then with them making changes in your healthcare system. And then, of course, change always is an ongoing process, so you need to keep making these changes. And these can help improve things in our system. Now, I know I talked a lot about how the upstream things are really, really important, but what I've known with this thing is that we can make a difference in this. Just things like the ARES pathways, clinical pathways, these are all things that we as physicians and healthcare workers can do. And so I want to end with that note of optimism. The data is very upsetting. But I think we can each learn from this and make a change in our system and improve our perioperative patient safety. Anyway, thanks so much.
Well, I think we have about 5 minutes for questions. If people are coming to the microphone, I'll start off with Karen. What are some of the actionable steps that we can take to, and I noticed your graph showing a poor mapping of the demographics of the medical workforce to the U.S. demographics. So what are some of the actionable steps that we can take to improve the diversity, inclusion, and belonging of our workforce to improve health equity?
Okay, well, a lot of these, for instance, the whole issue comes with the MCAT as an example. MCAT's catered towards rich white people, really, to be honest. And I don't think it doesn't predict performance, particularly in medical school. The other thing I think is trying to, reach out to our communities and give kids in high school, junior high, go out there and show them things like doctor exhibits. I mean, right? You take a stethoscope, you do these sort of outreach. Yes, it takes time. No, we're all busy. But that can show people, and especially if you have people of color from those areas, can go out. They say, hey, I might be that kind of person as well. And then, what about in high school? High school changes a lot of people, or in college, to be able to give people who are underserved populations an opportunity to have a few months in, as a summer rotation in our hospital, in our residency system, as an example. Yeah.
Lee.
Yeah, Lee Fleischer, Washington. This is great. Really commend you, and I think it's really important what you focus, not only take it from the top, but really locally. And I think that's fantastic. I had one comment and one question. Number one, I'm very concerned with us saying we have iPads, we can do translation. But then you talked about cultural and language sensitivity, which I think many of you may hear will be coming out of Washington quite loudly over the next several months. So thank you for doing that. There are new metrics around measuring social determinants of health, 5 particular metrics that hospitals will be asked to do. Where do you think anesthesiologists can lean into to help address those violence, food insecurity, housing insecurity, et cetera?
So where can we feed into that?
Yeah.
Oh, that's a challenging question, Lee. Also, yeah. I guess I think a lot of it comes from our local advocacy efforts with the communities, and also within the hospital systems as leaders of we interface with a lot of folks in the hospital, and trying to work with that, because I think it needs to come from the hospital system rather than the individual provider. But we as individual providers and groups can focus on that as for the hospital system to really think about that and how they can actually make some improvements in that.
Including the perioperative period.
Yes.
And Alice, looks like I can read your name badge there.
Very good. Alice Kim's from Richmond, where the story took place with the 340B program. 2 issues that I have. You did a great job, just fabulous. One is the notion and the understanding that several large studies have actually addressed this, and that is African Americans and Hispanics going to high volume hospitals versus low volume hospitals, and a tendency to go to low volume hospitals. But even when you consider elite institutions, and I think this was back in Archives of Surgery, when African Americans and Latinos go to high volume hospitals, they get the low volume providers. So even at a place where you look at the outcomes and the metrics for the general population, it's very hard to see the drill down impact of minorities at what we consider elite institutions, those that are ranked nationally, because many times they wind up with the low volume providers, and there are a number of reasons why that happened, but how do we address that issue going forward? Because I think that's a hidden conversation.
Yeah, well, I thought the slides in the beginning that show, these indicators of hospitals that affect in the, most of them are pretty good for white people, but down below, like for black people and that, they're all much worse. And so clearly, even in that same set of hospitals, there's a difference that you see that's obvious in that. Now, why does this happen in terms of quality of providers within a large volume hospital? I think that I'm not sure what those reasons are. I mean, maybe you could tell me other than racism. I'm not sure why one would have it. So I didn't read anything about that.
I will speak to one issue, and that's healthcare literacy and healthcare empowerment, and what happens with the engagement, especially around perioperative.
Sorry, we cannot hear you anymore.
So I think one thing that there's a lot of attention with non-surgical professions, specialties, is the whole notion of healthcare literacy and empowerment, and what happens when you talk about someone doing a procedure. I mean, the study with gastrectomies, surgeon, asking the surgeon, how many have you done, and can you give me a patient reference? You know, someone who's done 2 gastrectomies a year has really poor outcome with greater dehiscence and postoperative wound infection. So I think that the notion of healthcare literacy and healthcare empowerment is another thing that needs to be
Yeah,
addressed.
that's an outstanding thing. Thanks for, because that's really, really important, because it's part of the educational aspect of trying, you know, and that thing about approaching patients on that educational level, because they lack that, you know, and so they don't know to ask, you know, the question about that. And that again, I think, would be on an educational level, and perhaps again, we as, you know, anesthesiologists could try to help educate people about that. Oh, it's a little harder within our systems to do that. Yeah.
We have time for one final question. I will point out, though, I think there was an article in the last week or two. Essentially, the headline on that, it said there's segregation between hospitals and within hospitals. It's a very thought-provoking article, but I think if I can reach your name, is Keisha?
It's Keisha, yes.
Yeah.
What would you recommend if you find yourself in an institution where your presence, you know you're present because those disparities exist, and so it's important that you're there, and, you know, in your small silo addressing those things personally, and certainly trying to expand that mindset to those around you. But if you're in an institution where there isn't a lot of attention, a lot of interest being focused around these issues, how do you start to change that culture?
Well, I'm coming this just from my own experience as a woman. You know, I trained in a program where I was frankly told as a resident that women make good nurse anesthetists and bad anesthesiologists, and hopefully I really enjoyed my program overall, but it was definitely, I felt like a minority in that, even though I'm not. I guess one of the things I think of is trying to take, you know, if you have grand rounds or you have group meetings, to bring up some of the issues in a non-emotional, academic, you know, right, doctors like data kind of driven manner, and just start laying out, you know, some of the things. And especially at a local level, right? I mean, that's what drives people. They don't care what happens down, you know, in 10 states away in a different city, in a different hospital. They care what happens. And so if you can work with your administration in there, or I don't know what kind of set, you know, about a lot of the data that comes from your hospital, and bring it up as a presentation, as a scholarly kind of presentation, I think you'll find that people are open to this. I think COVID opened a lot of people's eyes. Yeah.
Well, thank you, Karen, for a very thought-provoking and excellent lecture. I think my only comment is that we have a lot of work to do, so thank you again.